Hello and welcome to Checking the Vitals, a podcast powered by Specialty Care. I'm Todd Schlosser, and joining me today is Dr. Alan Daniels, Chief of Spine Surgery at Brown University and University Orthopedics. In this episode, we discuss how Dr. Daniels found his way to both healthcare and to his surgical specialty. We also discuss how he handles training his residents and his theory on how patients should seek out the best surgeon for their needs. Enjoy the conversation. Well, Dr. Daniels, I thank you so much for joining us here on Checking the Vitals. I appreciate you taking the time today.
Thank you for having me.
Absolutely. So I'd love to start out with what it was that made you want to work in the healthcare space in general. Not necessarily orthopedics that we'll get into, but what was it that happened that made you think, I want to be a doctor or work in healthcare?
Yeah, so there's nobody in my family that is a physician. I went to University of California, Berkeley, and I was always interested in science. School came pretty naturally to me, so I truly enjoyed it. I thought I'd probably go to more school after undergraduate, and I was a psychology major. And I became interested in clinical psychology and figured out that I couldn't prescribe medication to the patients who maybe what I would say needed the most help in terms of really severe psychiatric disease. So I said, well, if I want to prescribe medication, then I have to go to medical school to do it. I did a little soul searching and rapidly figured out I was not a psychiatrist, but still knew that the medical field's where I wanted to be.
Okay.
And then I can tell you exactly why I became a spine surgeon, because the story's short, and that I got a job after undergraduate doing auto transfusion. So you take the patient's blood and cycle through a machine, you give it back to them. I was exposed to all sorts of different surgery. I saw terrible traumas, transplants, spine surgery, general orthopedics, vascular, and I just instantly fell in love with complex spine surgery. I knew that's where I wanted to be. So when I headed off to medical school, I said, I'm going to be a spine surgeon, and that was my goal.
So you knew going to medical school you were going to be a spine surgeon?
Yes, which is pretty unique. Most people go to medical school, they don't know what they're going to be. They go, I think I might want to be a surgeon, but I'm not sure if I want orthopedics or neurosurgery or urology. I knew spine surgery was where I wanted to be, and so I just had to make the decision between neurosurgery and orthopedics because they both do spine. Okay, so let's talk about that then. So when you decided spine's for me, why did you focus on just spine and not sort of neurosurgery? Absolutely. So knowing I wanted to be a spine surgeon, there's two ways to get there. Okay. You either do a 5-year orthopedic residency followed by a spine fellowship, usually a year, or you go do neurosurgery residency plus or minus a fellowship. So it's really two different unique paths to get to the exact same place. And what most people don't know, and I'm sure we'll talk about this, is that orthopedic surgeons and neurosurgeons can both do spine surgery. Same exact surgeries. Decompression, stabilization, fixation, fusion, deformity correction of the spine. Orthopedic residency consists of fixing people's bones, joints, ligaments, and some nerves. So you may do knee replacements, hip replacements, fix fractures, carpal tunnel releases with hand surgery, so we are operating nerves, and then spine surgery. In neurosurgery, they do brains, of course, they're neurosurgeons, so they do brain tumors and brain trauma. They also do things like carpal tunnel releases, but then they also do spine surgery. So that's the overlap. Yeah. And whichever way you get there is a perfectly acceptable way to learn, but it's a bit of a different background. And for me, I felt that I fit into the culture of orthopedics more, meaning that it just felt like those were my people, which sounds a little silly, but it's very true that these are your colleagues. And I felt that I fit in with that group a little bit more. Sure. The training was shorter. Now, that was not the reason why I would choose that, but it's a slightly more direct path in that there's less time doing the other specialties, meaning that I had to go spend time learning how to do hips and knees and ankles. Now, that's important because it provides background into fracture healing, fixation of bone, but I could spend more time then focusing on spine after my residency training. Yeah.
So, and I'm assuming you did a fellowship as well?
Of course, yeah. I did too. I actually did an orthopedic trauma fellowship, which is built into the Brown residency, and then I did spine after that. And I knew I was interested in spinal deformity, and really the history of spinal deformity comes from orthopedics. Now, there's a lot of neurosurgeons now that do spinal deformity, but if you look back into history, it really started with pediatric orthopedics and scoliosis, post-tuberculosis, kyphosis, and cerebral palsy. These were horrible problems, really tough to fix, that orthopedic surgeons figured out, starting about 100 years ago, that they could treat these things in casting with traction and then with Harrington rod fixation. And so it really started in orthopedics, and orthopedics still does the vast majority of both pediatric and adult spinal deformity in the United States.
And I'd imagine because of that is sort of your focus, here where we are today.
Absolutely. My focus is complex spine, and in the umbrella of complex spine, spinal deformity is kind of a niche, unique thing that most spine surgeons don't treat true global spinal deformity. It takes a certain skill set, but it's not only the surgeon's skill set, it takes infrastructure.
Okay. So what do you mean by infrastructure?
You have to have a hospital that can handle complex patients, meaning an ICU. If you're going to do really complex spine, you need to have vascular surgery close by in case there's vessel injuries. You need to have all sorts of support team behind you to help take care of these problems.
Okay. So once you have an infrastructure in place, you can then take on those more complex spine cases.
The point is, if there's someone out in a very small community hospital in the middle of nowhere, they don't do complex spine. Right. It's not within their wheelhouse to be able to handle the complications that inevitably ensue, to handle the long hospital stays, the very expensive hospitalizations, and pediatric spine's even worse in terms of children with cerebral palsy and myelomeningocele need huge support systems to try to take care of them. So it's best taken care of in places like Providence, Rhode Island, or Boston, or New York. And so small community hospitals certainly can take care of disc herniations and relatively simple spine problems, but they don't do complex spine.
Okay. So now you did mention Brown, which is, I believe, where you went to school, med school. Is that correct?
I went to medical school out in Portland, Oregon, actually.
Oh, okay.
Oregon Health Science University.
Okay. So did you come to Brown?
I came to Brown for residency.
Okay.
And we have a match. As you know, anyone in medicine knows that there's a match. People outside may not be aware of it, but you go to medical school and then you basically apply to all these residency programs, and they tell you where you're going to go based on a match. It's a complex algorithm where they say, where did you rank? Where did the program rank you?
Yeah.
And I matched here. It was a bit of a surprise on the day I did, and I said, wow, that's a long ways from home. I grew up in Colorado, met my wife in Oregon, so we moved across the country, and we never left.
Yeah. Awesome. Well, how long ago was that?
So that was, I guess I would have matched in 2007, so, 14, 15 years ago.
Yeah, so you come here to complete your residency and then just sort of stayed here, and I'd imagine that's when you sort of matriculated over to where we are today.
That's correct.
Yeah.
So I did my residency here, and I always knew that this was a great training program. There's a great history here of training orthopedic surgeons and spine surgeons. But as I spent more time here as a resident, I figured out it's actually a really great place to practice medicine. And you'll read, people love to email out these lists, right? In your email, you probably always see lists of like 10 greatest places to practice medicine. Yeah. Well, Rhode Island often actually is on the list of the 10 worst places to practice medicine on their list. Yeah, well, it's because people look at like Medicare reimbursement for procedures.
Oh, I see what you're saying. The finance side of it.
Yeah, but first off, I mean, that's crazy to think that you would think it's the worst place to practice medicine just because Medicare reimbursement is a little lower for certain procedures, number one.
Right.
Number two, there's a lot of other ways we're reimbursed in medicine. Medicine reimbursement is actually very complicated. And there's private insurance reimbursement and workers' compensation reimbursement and Medicaid and Medicare. And there's other things we are able to get paid for other than just purely professional fees. So, it's not so simple as to say just because Medicare doesn't reimburse as well that we wouldn't want to live here. Not to mention Rhode Island's a great place to live.
Yeah. It is beautiful. When I was driving in here today, I was really blown away with it. It's my first time in Rhode Island.
It's gorgeous. It's the ocean state. We have a ton of coastline. For the size of the state, we have the most coastline of any state.
Really?
And it's quite affordable compared to most of the big cities around.
Like a Boston or New York?
That's right, and it's close. My drive to work is less than 20 minutes, and Boston, New York are close if you like to be close to a city. And then also, the kind of more out in the country like Vermont, New Hampshire, Maine are close to. So I think it's a great place to live.
So I'd imagine that because of the location of the facility, that you do get some people from the more rural areas coming to you, or even doctors in Boston and New York, I'm sure get this too, because you guys can handle the complex spine cases.
This is a true regional referral center. Yeah. I would say that we're not so much of an international referral center like some of the places in New York and Johns Hopkins, but this is no question is a regional referral center. We certainly get patients from up in Maine, New Hampshire, Vermont, Massachusetts, Connecticut, because the problems we take care of really are tertiary care issues. And so we're a level 1 trauma center. We can handle any trauma that comes here and then get a lot of complex spine cases referred in.
Yeah. So with that, what are the common reasons someone would come to you for an evaluation and then possibly surgery?
Well, this Rhode Island being a small state, so there's two things that are true here. Number one, we are that tertiary care referral center. We get the most complicated, multiple failed back surgeries or rare tumors.
Okay.
But being a small state and is what it is, the most people that come into this practice are actually here for a little bit of back pain or a radicular pain, which is pain that shoots down the arm or the leg from a disc herniation. So we really do treat the full gamut. We have a lot of the patients that come here have relatively straightforward, simple spine problems.
Okay. So I'd imagine that there are straightforward, maybe not simple solutions to those, but there are straightforward solutions to those. And is it always surgery that fixes those? Is it, what options do they have when they come to see you for that?
I think, as you know, pretty much everybody that comes here is offered non-surgical solutions, and the majority of them succeed in not having surgery. And it depends how the patient got here.
Okay.
What I mean by that is if a patient has already been working with an interventional spine specialist, getting injection after injection after injection, they tried 6 weeks of PT, they've been on gabapentin or other medications for the last 6 months, they may be coming to me because they say, Dr. Daniels, I want to be fixed. Now I'm tired of this. You got to fix me. I've researched you. You're going to cure me. That's very different than the person who is referred here by their primary care doctor who goes, I've really had this aching pain in my leg for 2 weeks. It's absolutely excruciating. I would never even consider offering that person surgery. They need to go do all the other stuff. So we see both scenarios, but there are certain people who show up here ready to have surgery because they've done their homework, they've done all their non-operative care. And then there's the people who just showed up at this institution because they're trying to establish care for a new problem.
And I mean, pardon the pun, I'm sure it's always case by case.
Of course.
You got to look at them as the one patient you're treating and then develop a treatment plan that's the best for them.
Exactly. It's all individualized care is so important. And I'd say American healthcare does a lot of things poorly. I mean, we really have a huge problem in this country, and I have thought a lot about it. I've written about it. One thing that I'll say that we are able to do pretty well, though, actually, is individualized care for musculoskeletal problems. And because we have an extraordinarily expensive healthcare system. One of the reasons is that when someone shows up to my office, I'm going to say, you want medications? You want injections? You want therapy? You want acupuncture? You want chiropractor? Let's do it all. That is not the way it is all across the world. But here, we spare no expense. We'll do all that stuff. And then at the end of the road, then we'll do the most expensive intervention, which is surgery, and hopefully cure them of their problem.
I think it's interesting that, and to your point, there are a lot of problems in the U.S. healthcare system, but we are also the place that if you need something difficult done, you'll travel to the U.S. to do it. And I think that shows that people who are in your position, yourself included, are, I think, the best in the world at what you guys do. So I think where the healthcare system is failing is not at the surgical level, it's at another level. But I just wonder if you think that, or if you can attribute the fact that people travel here from around the world to have surgeries done. Is that an education? Do we have the best education? Or do we have the best practical application?
I think there is just like in most things in life, there's a bell curve of treatment quality in the United States. And I think our bell curve has some of the most talented, capable surgeons and institutions in the world at the top of the bell curve. I don't believe that the average care in the United States for spine is so fantastically above the rest of the world. But I think our ability to care for some of the really complex tumors and deformities is definitely as good and possibly better than anywhere else. And there's a lot of reasons for that. For example, I have a fellow coming next year who's from Syria. He's an incredibly thoughtful, talented young man, Basil Debo, who he came to the United States because he saw the potential. He said, I want to be, get the best training, be the best spine surgeon. I want to change the world. He saw the United States as an opportunity, as a place to do that. And I think a lot of people around the world will actually come here. There's a lot, Zia Gokaslan, who's just a spectacular spine surgeon here at Lifespan Neurosurgery. People have come from all over the world to get his care. Mm-hmm. And one of the reasons is that he's really differentiated himself as someone who does unique, cutting-edge tumor surgery. Now, I say that because he's been able to do that. He did it at Hopkins and then came here. And we do the same thing now with adult spinal deformity, that people will come from far and wide to get it done, is because we tried to build something unique or really provide that extraordinary service for people.
Yeah.
And so I know I kind of jumped around there, but to say that not only the surgeons have come to the United States that really want to do something special, but we've also built something where people can come from all over the world to get a relatively unique service.
Yeah.
And so let's put it this way. People wouldn't come from around the world to get average United States healthcare. They're coming to get those surgeons who are at the top of the bell curve.
Yeah, sort of the elite, if you will, of surgical techniques, surgical practices.
Right. So when you see American medicine at its best, it's as good as anywhere in the world. But again, the average healthcare, there's still really, unfortunately, below average spine surgery happening here commonly in the United States.
Well, and I'm sure with any profession, you're going to have people who are great at their job and people who are not awesome at their job. And I'd imagine that, we're here talking to you today because you are one of those that we would consider as great at the job. So I'd imagine that there are sometimes you're helping people who haven't had the outcome with the surgeries that they would prefer.
Unfortunately, in spine surgery, there's bad outcomes in the best of hands. So I have bad outcomes, even though I consider myself to be an extremely thoughtful, well-trained, well-intentioned surgeon. But importantly, I would say that there are some surgeons who are far below average, even here in the United States, where we have very stringent requirements for getting your MD degree or DO degree, and then getting your training, and then being board certified, and then getting certified to work in a hospital. There's still people who are really, I'm going to say, bad surgeons. And that's really disappointing in the United States in 2022. That shouldn't be that way. But the most interesting component of that is, how does a patient know if their surgeon is good or not? Yeah,
I would, as someone who's seeking out a service of any type, go to Google and do Google searches.
I'll tell you a really quick story. I had a young gentleman, college student, and he was seeing me for a disc herniation. He was really hurting, and he saw me a couple of times, and I said, listen, you're only 18 years old. Let's get you through this without surgery. I think I saw him 3 different times. We did therapy and injections, and I really kind of talked him off the ledge. I said, this is going to get better. I promise. You're 18 years old. Hang in there. And he went to Florida, and he got surgery during Christmas vacation.
Okay.
And he came back doing terrible. Yeah. Worse than ever. He was worse. He was one of these horror stories from spine.
Yeah.
And I said, what happened? You and I talked about this. You were doing fine. What happened? He said, well, this guy had actually operated on my sister, and I went home and I was struggling, and we had just decided I'd get done. So, well, how's your sister doing? He goes, she never did very well. I said, can you tell me right? So I said, can I see the surgeon? Give me the surgeon's name. So I Googled him. His reviews are like 3.5 out of 5, which I don't know if you know this, but in medicine, a surgeon, 3.5 out of 5 means that's not good, generally. I want to be a little careful about using too many, generalizations, because you may find a surgeon who I might say is good, and we'll look him up and he's 3.4, and I'll go, oh, well, that guy's good, but generally.
Well, case by case, like we talked about earlier.
Unfortunately, you've got to take case by case. Yeah. But generally, this surgeon had maybe it was 3.5, but he had 5 different people who said he destroyed my life. And we don't know how he got those other 5-star reviews. And I don't want to ever suggest anyone does anything nefarious, but their friends, their family, their staff might even be able, or themselves might be able to put in a fake 5-star review. So what I always said was, if somebody has a bunch of really bad reviews, you should really take those to heart.
Yeah. Sort of weigh the bad reviews more than the good reviews.
Right. The good reviews are super important.
Sure.
But they're pretty easy to fake, and it's unlikely that multiple people put in fake bad reviews.
Right.
But a good review is pretty easy to click in 5 stars.
Yeah.
Anyway, so I go back to this student. I said, would you go to a restaurant that had a horrible reviews and it said, there's cockroaches in the kitchen and my food was raw and terrible? Right. And he goes, no. I said, why'd you let this surgeon up here? He goes, I don't know. I didn't really pay attention to those reviews. I thought they were probably kind of BS.
It also could have been family pressure too.
Exactly.
Yeah.
But I was just fascinated that this young gentleman who's of a generation that's very focused on the internet. It's one thing if you have a 70, 80-year-old person who goes, I didn't know how to do it. I didn't know.
Yeah.
But this kid's 18 years old. He grew up on the internet.
Yeah.
I was surprised that he didn't take those reviews seriously. I think online reviews are super important.
Yeah.
As long as you know how to interpret them.
Yeah.
And so, some of the subtleties that we said, that if somebody has a number of really bad surgical reviews, like, for example, I know because I manage my own online reputation.
Sure.
I review it. I look, I see, hey, did someone give me a bad review lately? And I had a couple of bad reviews where someone says well, I was really upset I didn't get to see the doctor 1 star because they saw my PA instead.
Sure.
if someone has a review like that, I don't think you should look at that surgeon and go, wow, what a terrible guy, what a monster. But if someone has multiple reviews that says like, he destroyed my life, I had terrible complications, 5 people say they have infections, you start to go, wow, there's a problem there.
Well, because one is I would say administrative review, really, because they wanted to see you and didn't get a chance to, and the other one is a outcome-focused review. Like, my outcome was negative.
I think that's a good point, that outcomes are important. I remember my first bad review I ever got, the person said, wow, he's so arrogant. And I was kind of upset. I said, God, I came off the wrong way, and I thought, I should really try to be more humble. And then, in the end of the day, I wasn't devastated by that review. That yes, I came off arrogant to that patient. I did upset them and I feel bad and I shouldn't have. But at least it wasn't, I destroyed this person's life with a botched surgery. Right. I didn't slip with the knife. I didn't cut the nerve root. I didn't miss the diagnosis. And so I think you need to decide what's important to you when you're going to see a surgeon. And I always say there's a couple of things. Number one, your spine surgeon must have skill, in that if they don't have the necessary skills to perform the surgery, you got a problem. I mean, that's mandatory.
Yes.
And then number two, you want them to understand you as a person and what you want, and you want them to have the appropriate amount of empathy and have shared decision-making to make the right decision. And so if you have those two things, there's a pretty darn good chance that you're going to have, the best outcome you can have.
Yeah. Not to bring back the arrogant moniker, but I have found in my life, passion and confidence combined can come across as arrogance, but to me, it's different. And I understand that because I've had that thrown at me as well. And if you're really excited about something and very confident you can fix it or very confident you can do whatever, it may come across that way. So and honestly, that wouldn't bother me in a review. I would be looking for I went in with back pain and now I can't walk sort of review,
That's right. And that's exactly what I look at a lot of other surgeon reviews whenever some of the local people or anyone I hear that's operated on another patient. That's what I always look for, just out of my own curiosity. And to circle back on the arrogance thing, you realize that to become a surgeon, you do need to have a certain level of passion and confidence, which is the two things you said. And the term arrogance is certainly negative, but there is some level of probably arrogance it takes to put a patient to sleep, put their life in your hands, and also to be able to handle the negative outcomes. That we have a lot of empathy for patients, but you can't let it overwhelm you, and so you've got to have some healthy level to be able to dissociate between the troubles, the bad outcomes, and the stress when they do occur.
Yeah. So when you are looking for a orthopedic surgeon, or really any surgery, it sounds like, where do you go to find maybe credible reviews? Are there sites that you find are better to look for that information on?
Yeah. Google has recently increased massively in terms of popularity for surgeon reviews and for physician reviews. Historically, it was Health Grades and Vitals a lot.
Okay.
I personally, so my strategy, because me and my family go to doctors too.
Sure.
I look at all the physician review websites. So I'll look at Health Grades, Vitals in Google.
Sure.
And I just peruse the reviews, see what the average review is, but then read a lot of the recent ones. You have to be a little bit careful. So we use something called Rater 8.
Okay.
Rater 8 is great. Rater 8 is a way that you can see hundreds of reviews instead of just 15 Google reviews.
So do they sort of aggregate them all?
They'll actually aggregate them though from your own practice, and you have to be.
Oh, okay.
So it's interesting because Rater 8 is a little more aggressive about soliciting reviews from our own patients. They'll send an email after the visit. They'll say, you just saw Dr. Daniels, please provide us a review. So I have 400 reviews on Rater 8 instead of the 40 or 50 on Vitals.
Sure.
So you'll get a bigger picture. You have to be a little careful. I think there's a little skew sometimes towards the positive reviews, which is great. You get to see how many people they've helped.
Yeah.
But if you're kind of looking for those negative reviews, they may be harder to find. They're in there deep.
Yeah.
That's number one. Number two, looking for a physician in academic medicine is a double-edged sword, in that if you look for a surgeon who's truly in academics, you may either get a true thought leader who's the best of the best, or you may get someone who lets their residents and fellows do their surgery for them.
Okay.
So you need to be a little careful. And in academics, of course, we have residents and fellows help with procedures.
Sure.
But there are some educators that will really have the resident and fellow do a vast component of that procedure. And so you may not really be getting that surgeon doing a large majority of your procedure.
Is there a way to figure that out?
You have to ask the surgeon.
Okay, so you just have to come out and ask it. Okay.
And I think I think it's a very fair question, and people ask me all the time, and I'll give them the honest answer.
And I think that is, and honestly ties into the next point that I want to bring up and discuss with you, because you do teach. You are associate professor at Brown, and you, I'd imagine, have a lot of fellows that study under you, residents that come and work with you. How do you navigate that their need to learn, to train, to get sort of repetitions in surgery with the need of the patients to have the best outcome possible?
Very challenging.
Yeah.
Because you cannot perform spine surgery for the first time without practicing, of course.
Sure.
And you can't practice on patients. That sounds terrible.
Yeah.
So, of course, we spend time in the cadaver lab, for example.
Sure.
Practicing. That is practicing. I'll give you that.
Yeah.
As you head into the operating room and we have residents, the way that we train is through very slow and careful graduated responsibility and autonomy. And so if I have a resident with me, they're just assisting me, but they're watching each and every step and learning from each and every step. And as I become comfortable with them, there may be some very straightforward steps that they're able to perform. For example, when you make an incision on someone's body, it seems like such kind of a major part of the operation. It's technically pretty much the easiest part of the case.
It's like the first step, I'd imagine.
It's the first step. So you can have a resident make the incision. And I hope that patients are understanding that it's safe, it's easy, and it's not on your face, it's on your back. So it's going to be straight. But my point is, it's a technically easy thing to do.
Yeah.
And so we have the resident do that component. And that may be the only thing the resident does, and the rest of it, they're assisting me. But as the fellows get to be the end of their training, of course they can do more. In my operating room, I'm always there.
Okay.
There are some academic centers where the fellows will start the procedure, and that's okay, because the beginning of a spine surgery is actually the easy, safe part where you do the approach.
Sure.
As you get down to the spinal nerves, then maybe the attending surgeon will come in and do that component with the fellow.
Well, that's where things get more, and I'm sure dicey is not the right word to use, so forgive me, but that's where the bad outcomes can happen when if you sever a nerve,
a slip or a nerve that gets severed, or incomplete decompression of the nerve, and so that's where then direct supervision is necessary. And in the spine has two sides, right? The right and left nerve root.
Sure.
So if I'm on the right and the fellow's on the left, I may decompress the left nerve root, and I may, along with him, he may be taking some of the bites to decompress the right nerve root.
So this feels to me like I'm like an old school apprenticeship program where you are following a surgeon around, seeing what they do, and your first weeks, maybe even years, you're not really doing much practical application. You're observing and learning. And then as you get more time in and more knowledge into your belt, that's when you start to take over more control. And you as the surgeon who's training these people, and when I say take a step back, I don't mean literally away from the table. I mean, you just let them take on more challenging things, but you're always there to observe and jump in if need be. Is that sort of the...
Yeah, I think that's well said. And the final thing I would add is that our fellows are fully trained surgeons. They have finished orthopedic residency. They're what's called board eligible in orthopedics. They've taken their board examination. Sure. They're done. They could go into basically any hospital around the country, be orthopedic surgeons.
Sure.
They come to us to spend a little extra time doing spine surgery. The reason all that's important is they have attending privileges. They are actually orthopedic attendings. So as the year goes on and we've trained them and they've spent a lot of time focused on spine, they're actually able to go do their own spine surgeries as well.
Yeah.
And so what a lot of the patients they treat, some of them are trauma patients, some of them are acute problems, they will maybe solicit my assistance for some of the more complex parts of the case, but they'll actually be doing the surgery. It's their patient. And they'll say, hey, Dr. Daniels, can you just come in and help with a component of this, the more complex part? And so I'll help maybe with some of the planning and final execution, but they do the surgeries themselves. And that's how we have the graduated autonomy, where they've already finished residency.
Yeah.
They're trained surgeons. They come for fellowship for some final training and additional training in spine, even though they've already trained in spine.
Yeah. So, I mean, and we probably should differentiate between the residents and the fellows.
Correct. Two different things.
Yeah.
Residents require supervision, cannot start an operation on their own, clearly need some experience where they're learning from us. The fellows in our institution are fully trained. I say that because some institutions do not have fellows that have the ability to independently practice. They're actually kind of like glorified residents who are there just to do a lot of spine. In our institution, they have attending privileges.
Okay.
So they're clinical instructors. They have faculty appointments.
Okay. Well, much like you do at Brown,
Absolutely.
correct? Yeah. So, and if you don't mind, can I ask about that? Like, when did that start for you? Why did you want to do the academic side of medicine as well? Like, what was that pathway like?
It's all about mentorship. So coming to Brown for residency, I didn't really know what I was going to get into, and looking up to my mentors, who was Phil Lucas and Mark Palumbo, who you alluded to earlier, kind of two of the forefathers of orthopedic spine surgery here in this state, and helped build this practice. I looked up to them and said, God, I'd love to be like these guys someday. And when I saw that opportunity existed, there was an opening here, it was really too good to pass up. The opportunity to practice academic medicine is really, you have to be lucky in terms of the right time and right place, and of course be lucky that you've got the right skill set to do it. And what I mean by that is we have fellows come out all the time that want to do academics. There's no jobs for them.
Yeah.
Because there's really select few places in the country, especially if you have a geographic limitation. I mean, we have only a certain number of academic positions that exist. And so to be able and have the opportunity to train residents and fellows, do research, and contribute back to the knowledge in our specialty is really a unique opportunity.
So it's interesting to me that you see the academic side of it as, and correct me if I'm wrong, because it's your opinion, not mine, as more of a privilege than a right. It's not something that every doctor has or surgeon has the opportunity to do.
Absolutely. I think we have to be really careful in academics, because it is mandatory that you're teaching people the best kind of spine surgery. And I don't want to be too critical, but I just feel that some people out in the community may not be practicing best practice in spine. It may be the way they were trained. It may be what their local institution is able to provide. It may be their skill set is limited in terms of the breadth of spine problems they can handle. I think in academics, it's our duty to train people the right way to do spine. Now, there's multiple right ways to do it.
I was going to ask that.
So be careful when I say that, meaning that I'm not saying I'm the only right way to do it.
Sure.
But in my opinion, I'm providing the opportunity for my trainees to see one way, which is definitely, in my opinion, a right way to do spine surgery.
Okay.
It's right in that our outcomes are optimized to the best we can. We're performing ethical practice in that we truly have the patient in mind. We're not doing the surgery for ourselves for any reason. It's not, it is purely to try to help the patient, and that we are lucky here and that we can treat the full breadth of problems. So I say that if someone comes in with a horrible spinal deformity, I can treat that.
Yeah.
And I can show them how to treat it, even if the trainees are not going to go out and do that. There are certain rare tumors here that I tend to not treat, certain things that may need a en-bloc resection, but I will do the right thing, and I'll show the fellows how to refer it to the right person, because one of my biggest criticisms of spine surgery today is the spine surgeon who says I can treat anything. I think that's absurd.
There's just so much that can go on.
There's so much that can go on, but it's our specialty it's a point that our specialty's grown so big and so wide, not one spine surgeon can do everything well. Meaning, there's some surgeons who are really good at minimally invasive spine.
Sure.
Some surgeons are really good at spine arthroplasty, disc replacement. Some spine surgeons are really good at tumors. Some spine surgeons who are really good at deformity. If you're so egocentric to think that you're good at all those things, you're wrong. You're wrong.
And I'd imagine that falls down to, and to take a step back, I sort of see training to become a doctor as a big funnel. You start out in med school, you're learning everything.
Gotta learn it all of medicine.
Yeah, you go to residency to become a surgeon, you're learning surgery. Then you pick where you want to focus.
Right.
You pick spine. And then it sounds like you have picked more the deformity route within spine. So you're sort of pulling it all down into a focusing on the deformity of spine, which is awesome. There's clearly a huge need for that. But someone who is in your position may have gone almost exactly the same way, but they focused on tumors on the spine. And you want to get, if you have someone coming in who has that, I'd imagine you want to get them to that person who focused on that.
With one important caveat.
Okay.
Most spine problems are fully treatable by any reasonably good spine surgeon.
Well,
so what I mean by that is the run-of-the-mill disc herniation, disc degeneration, spinal stenosis. Even though I'm a spinal deformity surgeon, I would be honored to treat those problems. I do treat those problems.
Yeah.
All my trainees, I saw Peter Wagner's podcast you did with him.
Yeah.
He's a great surgeon. He would take great care of you. I know it. I trained him. I keep in touch with him often.
I didn't realize you trained him.
Yeah.
That's
I
awesome.
know.
Okay.
I watched his podcast. I said, Dr. Wagner, I watched the whole thing waiting for you to talk about me. I didn't hear, I said, what, can you tell me where to fast forward to where you talk about Dr. Daniels' great mentorship? My point is, and nothing against him, because he's a wonderful surgeon. Yeah. I may not send a complex deformity patient to him.
Sure.
Even though I know he treats some spinal deformity, but there's some deformities that are so complex, they should only go to the deformity specialist.
Yeah.
And so my point is that all spine surgeons should be able to take care of the simple bread and butter common spine problems.
Yeah.
But when you get into a really rare tumor or rare deformity, that should go to the ultra specialist.
Sure. So there's, and obviously I'm making up some figures here, but like 80% of all spine cases, most people can handle.
Absolutely.
Or 90, 95, whatever that is.
Sure.
But that last 5, 10, 15, 20%, you may have to refer out to someone who specializes in that specific type of surgery.
That's correct. And that's why I think being in an academic center where you're training people, you need to be able to treat the vast majority of problems. But even a place like our practice, there may be some problems that I eventually send out.
Sure.
Because you need to know your limitations.
Yeah.
And my hope is that anyone in medicine, any specialty, should know that even they have a limitation.
Yeah. And I honestly, you'd want someone who knows where their skill set stops.
Everyone has a skill set that stops somewhere.
Yeah.
And you just need to do, as a surgeon, a little soul searching sometime when a patient says, I want you to help me. It's actually harder to tell someone no to surgery than yes.
That does not at all surprise me. Just because you get into this line of work because you are a compassionate person who is super interested in spines, right? And you want to help the person in front of you who's in pain. Like, that makes complete sense to me. And I bet it is harder to refer someone out than it is to take care of them yourself.
Amazingly, it is for two reasons. One, probably the ego reason of saying, like, I think someone else can do a better job than me.
Yeah.
And I think in certain kinds of spine surgery, I'd say, I think I can do as good a job as anybody.
Sure.
But in certain spine problems, I say, you know what, that person is better than I am. And so that's the first reason. But the second reason is the patient trusts you. And the patient came to you, and the patient says, no, I want you to do it. And it's actually harder to say, no, I think you need to leave. It's just a hard conversation. You have to explain why.
Yeah.
And then the third reason, to get back to my very first comments about where we started today, in American healthcare, we shouldn't be, but American healthcare, one of the problems is the way that we're paid, which is, luckily, a lot of physicians are paid salaried, which is probably appropriate, but some physicians are incentivized by performing procedures. And so it's hard sometimes if you're not very busy for a doctor to say, I'm going to send this patient out, because you then don't get paid.
Yeah.
And you get paid to do the procedure. But that, as we all know, and I think most physicians do the right thing, that would be the wrong reason to do the procedure.
Yeah. So I'd imagine that, and you sort of alluded to this some, there are surgeons who are sort of set in their ways, maybe they've been out practicing longer amounts of time, don't have a connection to that academic world, so they're not really keeping up with what is new and what is going on in the surgical space. So do you feel like, because you are so tied to the academic world in that training of the new people coming up, that you are up to date with what is current and what is the best standard of care is what we say a lot? Yeah.
There's no doubt. And there's two main reasons. The first and foremost is, if you're doing academics, you are going to the annual meetings. Yeah. You are reading the research that comes out. You are citing that research when you're doing your own research. You know, not to say my research is so cutting edge that that's going to provide the best practice. It's that doing the background research for that research will help provide you what's really happening around the world, what people are writing about, what the thought leaders are doing.
Yeah.
And in spinal deformity, I'm part of the International Spine Study Group, or the ISSG, which is just a wonderful group of thoughtful surgeons who get together 4 to 5 times a year and say, here's what I'm doing, let's look at our outcomes, how can we do better? Super important.
Yeah.
And so that's the first way that we all keep fresh about what's doing. And you could imagine, when you're not academics, it's actually very hard to keep on top of all that. And you end up, as you age, you end up practicing more and more antiquated techniques. Now, your techniques may work really well, and it might be okay depending on what you're doing.
Sure.
But it's hard to know if you're not paying attention.
Yeah.
That's number one. Number two, trainees are one of the best ways to keep you on your toes. They ask important questions. Why do you do it this way? Is this really what you should be doing? They are also reviewing the literature. They're studying for their board examination.
So you're also getting the, well, have you heard this person
does
does it this way?
You get pushed, and it really does keep you a bit young as well. To be working with residents and fellows is a wonderful opportunity that, you know, they keep a fresh perspective on pushing you to say, are we really doing the latest techniques? Hey, can we try this? And it's, again, it's not the experiment. I had someone say, yeah, maybe we should be really updating our techniques now to learn this new technique. Let's go learn it in the cadaver lab, and we will begin providing this to our patients.
So it sounds like, I mean, unless you choose to leave your associate professorship, which I can't imagine you would want to do, but that's going to keep you grounded in that space and grounded in the innovation. So what sort of things do you see happening in the spinal surgery space over the next 3, 5, 10 years?
It's amazing how fast 3 years goes by.
Yeah.
And because when you say, well, what's going to happen in the next 3, 5, 10 years? I'm not sure there will be any major innovation in 3 years or even 5 years. But I will say that it's quite apparent that navigation and robotics will continue to drive spine surgery in better directions in terms of decreasing radiation exposure to patients. That's one of the most important things. It's not so much that robots or navigation are truly revolutionizing spine surgery, because they're really not. They're helping us just put screws where we already put them.
Sure.
What they are doing is decreasing radiation for the surgeons and the patients and the staff, and that's super important.
Can we talk very briefly about why and how they're decreasing radiation?
Yeah, so the traditional ways, and still a way that we commonly use, is fluoroscopy. You shoot an x-ray and it shows you where your instrument is.
Yeah.
If that looks good, you keep going with the instrument further, you shoot another x-ray, it's right in the right spot, and you put your screw and you shoot another x-ray, you show it's in the right place.
Yeah.
A navigation system will get an image, whether it's from a preoperative CT or an intraoperative image, and then will be able to guide your hand to put the screw, or guide a robot arm to put the screw in without all those those x-rays.
So literally it's just removing x-rays.
It's removing x-rays.
Yeah.
So that's one way of revolutionizing spine. And then further and more ongoing minimally invasive techniques like endoscopy, I think we'll continue to be able to do surgeries through smaller incisions. And then, even more importantly, at least in the spinal deformity space, is further study of optimizing our techniques to provide the most optimal surgery for that specific patient. So individualized patient care. Just because 2 x-rays look similar doesn't mean that the same surgery should be done on the same person.
Okay.
The person's frailty, their age, their general comorbidities, their desires, the flexibility of their spine. There's so many different factors that I think will continue to be able to synthesize. And then the surgeon's abilities. You may have the same patient go to 2 different surgeons that should have 2 different surgeries. Because one surgeon may have a skill set where he's really good, or he or she is really good at one thing, where that other surgeon's not good at that, and they should actually do a different surgery. So that's really complicated, but Chris Ames has done some great work at UCSF looking at this. We should really be trying to say, what are the outcomes in your hands? Because what I'm really good at, another surgeon may not be good at that.
That's one of those things that when you said it, it made so much sense to me. I was mad I never thought of that before, but I didn't think of that before.
It's really a strange thing to think, though, that if you go to 2 different surgeons, you should actually have 2 different surgeries. Yeah. Because you say, well, that doesn't really make sense. What surgery should I have? It depends who you see.
Yeah.
So patients sometimes will ask for cervical disc arthroplasty for me, and I'll say, you're right. For a surgeon who does a lot of those, you should have that. But for me, I do that surgery, but there's certain patients where they have a certain deformity, or I say, in my hands, I think a fusion's better. If you want to go see someone else, I'll give you a different name. Sure. But in my hands, I have a better result with a fusion. It's more risky to do the arthroplasty.
Interesting. Well, thank you so much for taking the time. I really appreciate you taking some time out of your busy schedule to talk to us for 30 or 40 minutes here.
Absolutely. I really appreciate the opportunity. And as I said, I'd just be honored to do it again.
Yeah, absolutely. We absolutely should.
Great. Thank you so much.
Excellent.
Thank you for listening to Checking the Vitals. If you enjoyed the content we provide, please leave us a 5-star rating and review. It really does help people find the show. And make sure you subscribe so you hear our interviews with healthcare innovators every Monday.